The one that I show you, introduce you, is Michela. And she has the chance to see that it stay on the back, vertical movement, not having any kind of horizontal movement. So it doesn't have any problem on that. Doesn't have any kind of bite against the upper. Okay, nothing to do that. Because she stay and remain in place, in vertical. Look Antonietta now. Antonietta is changing now. Look at the lower anteriors. Now you can see in the ralenti. You can better see from back. Look to the front, edge to edge. If she needed an elongation of the central incisor, you could have a problem at the beginning because you can have some lisping again, because you have not really a good sound in this case. So you have to analyze at the beginning what is the initial situation of the patient and try if you can modify or not. In that way, you should just let the patient know that could be possible, could happen. And you can say, listen, in some cases you have this kind of problem. In your case, you have going in front, and most probably you can have at the beginning some problem on touching teeth together, and it will be problem for you also phonetically at the beginning. Then neuromuscular aptitude is that to adapt to that, to the new situation, and that's normally disappear 99% of cases. But anyway, you have to be confident that the patient knows that you are aware about it and you anticipate them. That could be possible. In that way, you don't have the chance to say, doctor invented something. You know in advance. You have to take care. So you have seen the flat inside the ledge of the lady that we just presented a few seconds ago. Was flattened, not corresponding to the incisor ledge, blah, blah, blah. But now, that is the patient, the same patient. I'm sorry for the not good quality of the movie, especially the first one. But you can look easily, you can see she's going in front, edge to edge, right? So now on the right side, you see the elongation we made, 3 millimeter, 0.5 of lengthening that was added on the incisor ledge on the right side. And what happened there? Look now the movement. Just vertical, changed completely from horizontal to vertical. It was adapted. We are lucky guys, lucky ladies. Natural works that, not the Freudiani. It's just natural, working like that. But you have to test. In this way, you can do the mock-up. You have to lengthening, you can put the mock-up, and while you see that if they adapt it or not. How long does it take to adapt it or not? So in this case, we did some mock-up that was done. And at this point, we have added already some length. And we are creating, at this point, the possibility to optimize the level of the mock-up with the new incisor ledge position, no more flat like before, having added some length, having adapted in a proper way. And after adaptation that we have achieved, at this point, you can transform the situation that we have here at the beginning to the one that we have finalized properly in the final work. In that way, just to copy what you have achieved, tested, and approved by patient itself on the new length and new curvature. That is the goal that we have to achieve. The incisor edge position, the right one, should be, of course, the final goal. We have discussed quite a lot about aesthetics parameter, and especially anterior dental aesthetics. That is valid for teeth and implants, I believe. First of all, I would like to say we need to have an ideal dental composition. Sometimes even too much ideally finalized in an ideal situation. Sometimes it should be nice to have some little differences, a little characterization in order to really create more vitality, more valid life aspect of our teeth. But that is what the patient wanted today in every country, ideal dental composition. Symmetrical gingival levels, presence of interdental papilla in the right position, and then adequate collateral abutment, 2-4 implants, and last but not least, the use of ceramic restoration that allow you to achieve the best result. So we said ideal dental composition. Every patient, I said already, in all countries around the world want to become white and aligned, right? So actually, to obtain that, I believe that you can follow a kind of step-by-step solution, steps. So actually, first of all, inside that position, we discussed already, can be convex depending on the class. Class 2 become more convex, class 3 more flat. But in any way, should be any kind of curvature. Secondly, you should have the 2-to-2 proportion that see the central incisor that are really dominant in comparison to the lateral incisors. That is a mistake that many technicians have done on the last period. So, third, axial inclination, have to see the long axis of the central incisor that then become more divergent on the lateral and the cuspid, cervically. And fourth point, interdental contact areas that become more incisally, starting from the cuspid to lateral to central, creating a kind of a curvature that seems to be more or less similar to that of the incisal position. And then automatically forming from the central incisor to the lateral to cuspid wider and wider interincisal embrasures, wider and wider from central incisor to lateral to cuspid. And that, the two positions and arrangement see all the time lateral incisors that are comprehended between two hypothetical lines that you can trace between central and cuspid, cervically and incisally, both sides. In this way, lateral should be within these kind of limits. So the lateral incisor will be more coronal than cuspid and central. Not just that, also the papilla height should follow more or less this kind of level. This one level. Look. So when you see in the Congress a squeezed papilla between the two central incisors, nice, you have papilla, but should be in some way checked together with the other papilla height on the adjacent teeth, lateral and cuspid. Should form in that way a kind of a convexity. That's to be perfectly positioned in the proper way. So that is ideal. We will find in many other cases that I show you today, but just to tell you that that is something that must be done because the patient wanted to have it. I try all the time to do some little modification on the ideal setup because to create more vitality, but the patient normally don't want to have this kind of solutions that they want to be perfect 100%. At least in my country. Look at this case. We have root resorption. To make a long story short, we needed to remove all the 6 upper anterior because we had a resorption everywhere. So we have the chance to remove it, and this point was kind of a nightmare because having the chance to optimize the level of the aesthetic result of 6 upper anterior on implants, having one implant each other, close each other, will be more complicated. We couldn't increase the length of the incisors. We had already visibility of on the smile, as you can see from the left side. At the same time, we have already normal size, 10.6 as length. So you could not lose any kind of cervical border. Should be at the same level, should be maintained the same level, not to be apicalized. Because then you have to shorten the incisor, you cannot shorten the incisor. Because at this time, we have a nice ratio between the upper and lower anterior teeth on anterior guidance, so it should be kept in that way. So you could not really move too much. You have to keep the level as it is. For that reason, I asked my friend Eric Van Doren to come to my office to do the case together. We have 4 implants at the beginning on anteriors. We kept the 2 cuspids in cantilever for, of course, for having at the beginning it was, just a provision between cuspid and cuspid. And then when we had the chance to optimize the position of the implants and to await the osseointegration of the implants of the 4 incisor, we had the provisional that moved from cuspid to cuspid, provisional to the provisional made on the 4 anterior implants, 4 incisor, with leaving the 2 cuspid at this point with the cantilever for a while. And then, of course, we put the implants also in the cuspid area. So you have 6 implants at the end in all the anteriors. So time of surgery, 3 months after. So we could have the chance to increase also the thickness of the soft tissue on the back side through the kind of surgical precision that was done to position some connective tissue underneath. So in this way you can optimize the level of the gingival outline that remain practically inalterated. But at a certain point, we had the chance already to finalize the 4 anteriors, but we still have not conditioned the 2 implants on the back side, on the 2 cuspids. So we can copy the transmucosal path area that we can have here are conditioned by our provisional on the 4 anteriors, but not on the cuspids. I would like to show you how we can really be able, of course, to reproduce the transmucosal path area. Easy way to have the silicone index, the silicone that was, really optimized. This way you can add some, also some light cure, some light material on impression to have more precision of the contour over there. And you can, in this way, copy what happened on the provisional. That could be possible in the 4 anterior that was already optimized in terms of conditioning. Not on the 2 cuspid that was still not having the chance to do it. In this way, you can have the impression copying that are customized in order to copy what happened already on the anteriors, on the 4 incisor, but again, not on the 2 cuspid yet. But again, we know how difficult it is to achieve the best result when you have anteriorly 2 implants close each other. Can you imagine when you have 6 implants close each other? It will be even more complicated, of course. That is more or less what happened here. We have to copy the 4 anteriors, but we have to invent, being the technician, the cuspid area. We checked already the 6 upper anterior zirconia abutment that has to be idealized 100%. We put in the patient mouth. You look at the contour from a crucial view, you see that it is completely maintained. There is not any concavity on the back side. It means the surgeon did great work with the connective tissue graft that was positioned on the back side. But are we happy for that? Could be happy for that, looking this patient in that way. But if you look backally, oh geez, not the same. Not the same. We still not healed properly, and not completely mature. Plus, we have a very different kind of level of the gingival outline. The 2 central incisors are not identical. Should be identical, the 2 central incisors. The cuspid one is much higher than the other one. And what about the papilla? Very constricted inside. So now I could find an important strategic role for the prosthodontist in order to optimize the final outcome. That is not really comparable in what I obtained theoretically on the left side. That should be ideal. That is an ideal situation, and what the other one is not ideal at all. How can we modify? We can have the incredible chance to do and to improve our final solution, having in our mind what is our goal. That is to increase the length of the cuspid on the right side, to decrease the length of the central incisor on the left side, and to create some little more space for our papillas. So what is interesting on implants, different than teeth, you can play with not just with the crown design, but also with the root design. That's an incredible advantage that we have with implants. I remove the abutment and I reduce the shoulder and the chamfer that I put backally. I'm reducing that, the soft tissue will collapse down. That is the mechanism. So in this way, you see the provisionals. Now I remove, I change, I reduce the little chamfer that I have done, and then I refine it. And then with the provisional in place, I was reduce the buccal convexity of the provisional, reducing the thickness there, and creating some more possibility to create some collapse of the provisional down. And that was done with the provisional in place, with the abutment. So it's reducing the back support. In this way, you can alter the soft tissue level by a prosthodontic design. The design that you have created can allow the soft tissue to collapse down. Practically impossible with the teeth is possible vice versa with the implants. And that can be very helpful in achieving the best result. So look how is the over contour over there on the provisionals, and you can have the chance to cut back. In 1 week, you have improved already. Not perfect yet, you have to still press more volume, put more volume on the back side, on the right cuspid, but the rest was increasing by the way. Unfortunately, the patient talked to us and say, at this point, unfortunately, I need to leave and to go away, to stay 1 year at least in Australia. They said, okay, but you finish the work. We have to rush the finalization, so that is the reason why I did already the case in any way, finalizing, and not waiting for the maturation of the soft tissue even more. Zirconia abutment was positioned there. The zirconia crowns with the cut-cam technique was used, and was then layered over, following the silicone index that was showing all the rest that was already tested with the provisionals, so we can copy on the silicone index all the shape and contour that was working well on provisionals, layering the ceramic that we have underneath. In this case was zirconia. So layer it properly with all the effect that you can achieve on that. And even though it was not ideally at all, now you can see how we have modified the final situation. Seems to be even not the same case. That is nicely done. The patient left, and 1 year later, that was the final outcome. So we try to analyze what we have done in this case. All the concept was really more or less achieved. I mean, we have achieved an aesthetic and biological integration. Quite evidently, we have the chance to see that we have a interbone peak level that was remain unchanged. And 1 year later, I could say is quite nice finalized. Even the papilla height will be better than before. And once more, we can see the dental composition, incisal position, interincisal guidance, and interincisal angles wider and wider from central incise to the cuspid, lateral incisor between the two lines, as you said. So all the steps that you have seen already are within this picture. Even the papilla height, that was complicated at the beginning, that was obtained again working and playing with the provisional setup, with the provisional balcony and modification of the root and the crown of the implant in zirconia abutment. That is more than 10 years later. At this point it's 13 years later, and that is become still quite nicely finalized. No big difference between before and after. That is smile of the patient. So smile line. Smile line is important. How many people have this smile line? How many people have average smile line? How many people have a low smile line? That is the TN article. Differences are possible to find in every country. Also in the way are you able to really say something that can be able to laugh to your face. That is not easy to find it. So, oh geez, that is a very difficult case. How to treat this situation here? It's not easy, because you have a lot of problems. You have an occlusal problem, biological problem, aesthetic problem, and maybe if you have this smile line that is not so high, you can have some protection on the final result you can take it. So hopefully it will be like that. So you don't see what there is underneath on the upper jaw, with the level that is different from right and left. If you be like that, still okay, but you see the papilla height at a different level, right and left. But if you be like that, it will be a disaster, because you can see everything you have underneath. So, what will be the real clinical situation? Oh geez, not good at all. You have to do our maximum effort to achieve the best result at this point. And what you do? In this case, you have to establish a new incisal edge position. You have to establish a new harmonic occlusal plane. You have to establish a new gingival levels. So, the question is, you have seen before on the lady, Hélène, that we have done a kind of mock-up solution in order to understand if you can add some length or not. The question now is, can you do that also in this case? And what will be the answer? What will be the answer? No, of course. Why no? Because you have not to lengthen the teeth, but you have to shorten the teeth. So the mock-up is a reversible technique that allows you to have a very good preview of the final work, but just without having touched at all the tooth structure underneath. In this case, I cannot do it. I need to touch a lot. The tooth exposed at rest was on the right side of the central incisor, 9.5 millimeter. Unfortunately, I don't have this case showed you. It was written in the piece of paper because it was 27 years ago. So I didn't have this kind of picture. But I tell you, almost 1 centimeter of overbite on the right side of the central incisor. So can you do mock-up? No, because you have to cut, not to add. At this point, you have to select at this point in a way that you can find it yourself, the new incisal position. You have to calculate more or less that situation. You have to shorten the incisal edge because you have a very deep anterior relationship between the central incisors, upper and lower. You have to reduce it to avoid to show so much teeth at rest and during the smile. In this case, we did it, and we recollocated this kind of margin and that way. So now, the starting point of our treatment plan will be the head of our implant. If you do implant, the final outcome, the final gingival outline if you do periopros or orthodontically. That will be guided by the prosthodontist that tells the specialist on implant, on ortho, how to decide, how to collocate exactly the position of the upper teeth. That's the point. It's our duty that to find the position. And then the implantologist, the periodontist, the orthodontist have to follow our instruction in order to continue the remaining part of the work. So you have to shorten that. You have to shorten that. So you look at this case that was a really complicated one. Some important steps are to be considered also the periodontal kind of problem that we have anteriorly, especially on the lateral incisor on the right side, that has to be removed, of course, but all the perio process to be done in the remaining part. So we have a rehabilitation of a complex case in our office at this point. So, again, look at this. Complicated, very complicated. What about surgical evaluation? What about prosthetic evaluation? We need to create a kind of anticipated surgical and post-surgical change, creating some gingival tissue symmetry and creating some marginal tissue stability. On the other hand, you should be more or less like that, as you said. At the same time, you should shorten the incisal edge, evaluating aesthetic, phonetic, and functional parameters, pre-visualizing the final incisal edge position, and estimate also the final tooth length. That is what you do. That has to be done by ourselves in conjunction with maybe the orthodontist, maybe the periodontist, maybe the implantologist. It's up to you. It's a teamwork on this case. Of course, yes. In that case, we have done all the case periodontal prosthetic work, but was done in 95, so 27 years ago. So that is the periopros treatment plan, what was done. And that was the surgical procedure by Roberto Pontoriero, a periodontist that passed away last year either for COVID, unfortunately again. So you see now the situation in front of you. Actually, if you remember that we said before, the normal central incisor length is about 11 millimeter, 10.5 to 11.5, more or less like that. What about this length over here? It's about 18 millimeter, 7 millimeter more than normal. But what happened now? We still have to shorten the incisal edge, that is not in the right position yet. We just have it in some way optimize the right and left together, but not shortening the whole sector. Plus, you have to consider also, after the periodontal work that you've done by the periodontist, you have to create new kind of attachment. It's a connective epithelium attachment, 1 millimeter, 1 millimeter, 2 millimeter more, plus the coat of sulcus that was formation after healing and maturation process, after periodontal treatment. At this point, you have to an increase of covering this cervical area of approximately 3 millimeters. You have to shortening 3 millimeters incisally, you arrive at about 11.5 millimeter length. That is more or less what you have to do. But let me show you. So starting point is always the evaluation of the incisal edge position and tooth length. That is the starting point. So healing phase, again, you have to create this kind of decreasing the length of the cervical, because you have increasing the covering of these with the formation of the new attachment. When you do the canal lengthening procedure and reposition the flap of the bone crest, you have to consider the new attachment formation. 1 millimeter connective tissue attachment, 1 millimeter epithelium, and 1 millimeter sulcus. That's average measurement. 3 millimeters of growing up. 3 millimeters of growing up. So, what about two things? What about how much they grow on the cervical area, and how long does it take? It's also important in terms of having the chance to optimize the case over time. So that is what happened. I tell you why I was shortening so much. Starting point, 18 millimeter at the beginning, and that is 3 millimeter, 3.5 on the cervical area. Again, with the new attachment formation that was automatically achieved when you reposition your flap at the bone crest, okay? And that they start 3 millimeter of growing up. Again, 1 millimeter of connective tissue attachment, 1 millimeter of epithelial tissue attachment, and 1 millimeter more or less about the sulcus depth. At the same time, we have shortened incisally other 3.5 millimeter. And that's what the starting point of our evaluation, remember that. So altogether become around 11.5 millimeter. And that is what I wanted to achieve as final result, as I said at the beginning. So the marginal tissue stability from 5 to 12 months, that is more or less what the articles on this topic can show you. But at the same time, not just the aesthetic problem was I had to fix it, but also the functional problem. Look at the occlusal plane. That was completely wrong. We have to extract all the lower anteriors. They are not supported by the periodontium in a proper way. They were, of course, not possible to finalize the case with the presence of the anteriors. So at the same time, it's something that was needed because the periodontal support over there was minimum. At the same time, it was very useful to optimize the occlusal plane, as you have seen here. And having now created some occlusal stability with a very fixed contact from upper and lower anteriors, differently than was present before on the stone model on the previous case. So we have to change the occlusal plane completely, but at the same time also stabilizing them in order to be fixed in that position. So now, of course, we can have the chance to recreate a new provisional setup, having shortened in that way with 11.5 millimeters with a new provisional setup. At this point, we have waited for almost 1 year, 11 months, to finalize the case. You see that we provisional now, we can go into the sulcus depth because we have waited not just the healing phase, but also the maturation time. That is longer on the interproximal area than the back side. We have the chance to arrive up to the gingival outline. We obtain quite nice biological integration. We have also tried to condition also the dental interdental areas in order to create some ovate pointing design. So we position cervically inside the sulcus depth for just minimal amount, keeping the nice kind of final biological integration, even though we have positioned our margin inside the sulcus. And that is the final outcome of our provisional. At this point, we have to transfer all this information to the final work that has to be done with the final work in metal ceramic that was done at this point 27 years ago. So upper teeth are joined together, each one. Lower arch finally was divided in 3 different bridges, molar bicuspid, and cuspid to cuspid. So 3 bridges on the lower, one bridge to join all together the remaining abutment on the upper jaw. That was the final impression. Lab communication, we have a copy, the provisional that we have already tested and proved in the mouth with the silicone index. And in this case, we have the silicone index that was done. A metal framework design was created within this kind of limit, a border that was designed by the provisional on the silicone index. We put the patient in center relation position. We discuss later on about this. With the remaining the vertical dimension that was before, we didn't need to increase it. At that point, we have optimized the work we use in the porcelain fused to metal, arriving with our ceramic to cover all the metal and having on the margin 4 different kind of thickness, that of the metal, opaque, dentin, and enamel. Giancarlo at that time was doing a great job anyway. So we have a very reliable technique on the metal ceramic. We have the possibility to create a soldering procedure that's not possible with zirconia, as you know. So if you have some rocking, you can cut and solder on metal ceramic. You cannot do anything with zirconia to do again. That is something that we know, that we use anyway, zirconia, because of course we like to have white teeth and not dark teeth. So metal ceramic have a lot of incredible advantages, long span bridges, long-term follow-up, again, soldering procedure. But everybody, comprehending myself, using zirconia every day because we want to improve the aesthetic result, and all the people want that kind of result in their work, their final work. So that was the beginning situation, and that is the final work that was finalizing. We had also functional aspect to be in some way optimized. The objective, the goal was to establish occlusal stability in CR, recreating optimal overbite and overjet, reestablish correct anterior guidance for posterior disclusion during exclusive movements. That was the beginning situation, the final work that was obtained with X-rays, initial case, final case. Initial case the other side, final case the other side. That's what was nice work to be done, and we enjoyed this kind of treatment. That time was 95, long time ago. We started the case in 94, we finalized the case in 95. And we have obtained quite nice aesthetic integration and also biological integration. What's interesting also to understand what happened next. Many times we show the case as soon as they finish. It looks nice, great, but we don't know what happened next if you don't take the picture of the patient regularly. And if the patient doesn't come too far away. In this case, this lady is Paula, and Paula lives in my city, 300 meters away from the office. So he's a patient that I can see every day, just also meeting in the street. So in 95, we finished the case. And we started again with the treatment plan with the incisal edge positioning. Remember, not having the chance to do the mock-up, that was impossible to be done in this case because it was to cut, not to add. But that is 95, calculating all the steps and starting with the ideal positioning of the final margin, the cervical margin, and final length, we obtained more or less this kind of result in 95. That was great. Incisal edge curvature, parallel to the lower lip line, a little gingiva visibility of the old teeth length. That's nice. The parameters are the one that you want to achieve. So that is the case that you can see 27 years ago. After. So that is the case that I just take a picture 1 month ago. That was really maintained in a proper way. Longevity is the most important step that has to be followed in this case. Is that the 22 is not everything identical to what you have obtained before. You have removed one tooth and put an implant, as you can see here, from the arrow, red arrow, but still maintaining the nice final outcome. And once more, rest position and incisor position. And rest position, couple of millimeters, and incisor positioning, the curvature of the incisor edge. Little space between the two central cervically. That doesn't mean too much, 27 years later. If I would like to cover that point, I could add some lateral little. We need to be in front of the audience saying, look, it's perfect. I don't care, that is perfect like that already. I would love to have a case always going ahead in that way. That's the goal that we have achieved. So after having discussed about this kind of situation on aesthetic parameters, I want to talk about treatment plan on systematic approach on terms of function analysis. I would say our goal is that to obtain the best function, to provide the muscle comfort, to minimize the load in TMJ, and to control singularly the load in every teeth, distributing the load in the proper way, not not focusing on the load just in one specific tooth. That is very dangerous. So what you have obtained normally is to have an even load distribution in each tooth, reducing the load in the teeth and in the joint. So we should have a synchronized, punctiform, equal intensity kind of contact on posterior area. On the contrary, light contact on anterior area, but ready to become a kind of a starting point for our anterior guidance and our posterior exclusion. So why we put the patient in CR? Why we should have the chance to say we want to use the CR position, differently than maximum anticipation or acquired position. Why we do it? For simple reason. First of all, because reproducibility. For us, in pros, it's very important to be possible to do the cross-mounting procedure. What that means? I want to do and to copy something that's working well on the patient mouth during the provisional phase. On the final work, I don't want having any kind of difference between provisional and final, just the material type. That's the only situation that they want to change it. So it's very important to keep the same kind of position of the teeth. And that is possible only if you have all your bite records exactly at the same height and position, the same level of the video, at the same kind of position. CR mandible position is the one that can be repeatable. In all our courses that we do in our facility, we have the chance to have all the students that achieve this final result at the end. The CR position is possible to be reproduced with different methods, with the lift gate, with the lucid jig, with the dose maneuver, as you like it. But that has to be possible in order to be able then to copy that to the final work, and not to have to invent each time different work from provision to the final. Many patients complain when you have the provision in place, oh, they are happy, I feel comfortable, they have already the habit to have it maybe for weeks or months, and then you change all their parameters when you deliver the final work. That's crazy. That's crazy. It shouldn't be done in that way, because the patient, of course, complain. Say, but the provision was shorter, more out, more in. It's different. It's different. That's the problem. You should find a way how to optimize the provision, and once you do it, you have to have the ability to absolutely copy that to the final work. That is the point. Plus, oh, sorry, I did wrong. So, second one, if somebody told me, I want to keep the maximum anticipation position. I want to keep the same acquired position. And the problem is that when you cut the teeth, as in this case, Jeffrey Hawkinson said to you, if you cut the teeth, because the acquired position is just a dental position, not the articular position as is the CR, at this point you lose all the information you had before. Once you cut the teeth, you don't have any more the dental position. Dental position is lost in 1 second when you cut the teeth occlusally to do the new case. So the MIP is not possible to be kept, and that is not needed to be used. It had to be used a repeatable position. As I said before, the reproducibility of the CR position is the main goal in our cases. When you use at this point clinically the CR position, when you have to do 1 arch or 2 arches on all the posterior area to be done, and also the presence of the anterior attrition on that area. That was the same situation that you can have. How you do it? We said already, by manual manipulation, lift gauge, Lucid G. One of the 3 can be used easily. When you talk about posterior, we said already, very important, stabilizing contact on posterior area, light contact on anterior for disclusion. Light contact means not fremitus when you touch the teeth on the back side. If you have a fremitus, you have to reduce the load over there. So it's very important, the function. Normally, we say 2-3 millimeters is okay over bite over jet value. It's a very generic value. You have to look what happened live in the patient mouth. That's the point. And what you have to do that? You have to say that for every 10 degrees of change of the steepness of the angle of discussion, there is 35% of involvement and of the force applied. It's changed 35% more. If you have a steepness of the anterior guidance, you can really concentrate more load over there, creating problem. So the ideal one is to be as flat as possible, but at the same time avoiding any interferences on posterior area. So flat enough to be ready to move easily the mandible, but at the same time to have the chance to disclude the posterior teeth during excursive movements. So for that, it's very important to try to increase always the overjet value. The overjet value should be properly formed. If you have not the chance to do it, you have to try to create as much as you can in order to have a kind of less concentration of the load on some specific area. Anterior guidance steepness reduction is our point, is our situation. That has to be clinically achieved. This form of rehabilitation is an example of what to do in this case. And of course, you have to show yourself always how it works. Just 20 seconds of maybe a little movie. When I do all the cases on full mouth rehabilitation like that, I try always to do like that. And to say the possibility to see how the patient moves easily. Frontally, laterally, left side, means you that working well. It means the patient doesn't create any kind of steepness in any kind of guidance. It doesn't create any kind of problem on that. So all these steps are, of course, showing that on the books that I've finalized and translated in 12 different languages. And of course, after that, I did already static analysis work on the lab chart, on the statistical analysis, and then on the second volume on the lab chart, just to communicate with the lab all the steps that you needed to follow. Technicians are not the inventor, are not the magician. They cannot always be able to catch the point. They need to be informed in a better way, much better than we normally do, all around the world the same. They are receiving just tiny information. That is really ridiculous. They should receive as much information as possible to achieve the best result. Lab chart is one of the ways how you can communicate with them. Today we also form an application. We go from analog to digital. We started to use this kind of solution here. The main steps are just guiding the get up, the digital solution. I don't want to do so much about that, but just having the chance to have not just picture, but also movies is already important. Movies are very important. Remember that picture that you take sometimes in order to give some information to the dental technician is just a moment of a dynamic action. So picture is just a static moment of dynamic action. Doesn't represent all the time the real life. The movie, yes, you can see all the steps, but not on that, not on the picture. So anyway, I don't want to bother you with this. If you are interested to use it, it's ideal to really follow a kind of treatment plan. You have a kind of rendering procedure to show all the setup is very completed. For the people who would like to see occlusion and aesthetic together, will be great result on achieving that. You can modify as you like it. You can be guided by the application 100%, or you can influence the application to follow your instruction. It's up to you. So I don't want to say, after that you can use any kind of solution to go ahead with the work. Once you have all the data collection that are in your hands, at this point you can follow a kind of analog or fully digital approach. And
Gianni,
we stop in the middle.
don't you think it's a good place to stop now and have a break for 15,
Okay.
20 minutes?
Okay, and we start with Max later on. At this point, we stop for 20 minutes.
Yeah, we'll stop for 20 minutes for a coffee break, and then we'll get back exactly in 20 minutes.
Okay.
So 10:30 we'll start the
20 minutes
second
be
part
here.
of the lecture.
Test, hello, check. Test, 1, 2. Check, hello. Hello, check, hello. Test, 1, 2. Check, hello, check. أنا فصلت أبو سلمان. اسمع صوت. تشيك الو. هلو تشيك الو. تيست 1 2. تشيك الو تشيك. تشيك الو. هلو تشيك الو. تيست 1 تشيك. check. Test 1 2. Check, hello, check. Test 1 2. Check, hello, check. Test 1 check. Test 1 check. Check, hello. Hello, check, hello.
Assalamu alaikum. For the next lecture, I would like to welcome Dr. Haifa Al-Banna. Dr. Al-Banna graduated with a bachelor degree in dental surgery from Punjab University, Pakistan, 1999. Afterwards, in 2002, she obtained Part 1 of the membership of orthodontics from the Royal College and followed that in 2005 with membership in from Riyadh.
Working, yes. I did 1 hour and a half. So, I would like to start my presentation in the afternoon, no, the second part, sorry, with the definition of MIPP. That was the title of my presentation too. It's a kind of prosthetic procedure with the aim, with the goal of saving as much tooth structure as possible, maintaining an enamel for predictable bonding. That is the point. Nothing really new, but it's the combination of all the steps that you see later on. You will understand why I count so much about MIPP. MIPP 0, 1, 2, and 3, just to be short enough. I would like to say we divided the solution, the situation, clinical situation, in two parts. One was the keeping the existing occlusion in an MI, maximum decompression position, acquired or habitual position, with a confirmative approach. In that case, you have MIPP 0 and 1. MIPP 0 is additional restoration anteriorly and posteriorly, like onlays on posterior, veneers on anteriors, with no prep, mainly on enamel. And the other one is MIPP 1, when you have a partial restoration, again, veneer in posterior restoration with two structure preserved mainly in enamel. It's not the same. MIPP 0 when you just having an adding procedure, and adding veneers or onlays. MIPP 1 when you cut the teeth, when you grind the teeth, and you have some kind of prosthetic procedure that is done, preparation, two preparation. That's MIPP 1. Both of them are in the confirmative approach. When you don't go to the CR, when you keep the occlusion as it is, acquired or habitual or maximum decompression position, okay? On the other side, we have MIPP 2 or 3 with a reorganized approach. So with occlusion modification, putting the patient in CR. And again, MIPP 2A is a partial restoration like MIPP 1, so but in CR, not in MIP, in CR. Enamel preservation is, of course, a big point for every case. MIPP 2B with a full veneers in case of open bite in CR. Sometimes you have an open bite, or sometimes guiding the patient in CR, you will have the chance to see an open bite. In this case, you have the patient that has to put in CR with the enamel preservation, and you try to do the full veneer, extending the buccal veneer on the palatal area with the crown design, but with the veneer heart, with the veneer, heart inside, not a crown, classic crown, but just not touching the posterior. When you have an open bite, we don't have to touch the palatal part of the upper teeth because you have already space due to the open bite. And then you have MIPP 3, A and B. A is one arch, when you treat one arch. MIPP 3B is when you have taken care about the two arches. And just speaking, the MIPP 3B is the main goal that you have to discuss today, because you have a lot of steps that have to be followed in a proper way. So MIPP 0 and 1. But before dying that, I would love to say, big important is when you have to deal with the anterior area, especially with the final outcome will be a perfect situation between the preparation and the soft tissue management. That's a case that was done long time ago, about 25 years ago, but just showing what? Showing that the preparation modalities was not so minimal at that time, but the color of the battlement is normal. In all these cases, on anteriors, we still prefer to use silica-based material instead of zirconia material, frankly speaking, myself. Plus than that, we have also the advantage on the silica-based material that you have an etchable ceramic that can be etched and can be salinized, but the same wine can be really strong, but keeping the best solution in terms of aesthetics. Aesthetically speaking, I believe that the silica-based are superior on that. And the goal is aesthetics and the light transmission properties that shows going through the tooth, achieving the first result, even a minimum thickness. You can achieve this kind of a blending procedure between tooth and restoration and gingiva. They are similar on the right and left side. Just showing you that these materials have a transmission properties that are very similar to that of a natural dentition. And that is the main point. The the goal, natural light transmission properties. So all the pictures you see now in this part of my presentation is related to silica-based material, not to zirconia. I have another lecture that, of course, talking about that, zirconia material, but not now. And the MIPP, it will be, again, done normally just with silica-based material. What is MIPP 0 and 1? We said already. Additional additional veneers or even prepared veneers with the space like that can be both. Can be just apply over, or you can grind it be on the teeth in order to have a better kind of final outcome. But in both cases, you can have the chance to really avoid to go to the CR position in this case. With just existing position, MIPP 0 and 1. So partial restoration with two structure, preservation made on enamel, veneers or onlays, for example, but without having any kind of preparation modalities in the proper way, and keeping the occlusion where it is. So before and after, that's a very easy case that can be done. You can just cover these holes, these diastemas in the proper way with the both MIPP 0 and 1. When you talk about MIPP2, we start to become more comprehensive, even on the treatment plan. I would like to show you a case on this guy. This guy has class 3 maxilla, vertical and anterior posterior deficit. So practically, he has no incisor exposed at rest and have the flat incisor ledge, but especially not showing teeth at all. So that was a problem that cannot be solved just by ourselves. You have to send the patient to the orthodontic surgeon in order to be, in that way, prepared in a proper way. So we have MIPP2A. Is a partial restoration that can be done with occlusal modification, putting the patient in an enamel situation with the ECR position. So the inclination of the inclined long axis of the cuspid especially was really inclined that way. So we would like to have a better final situation, but to have the case to be finalized, you should go through the orthodontic surgeon. So the goals are recreating overbite over jet value with tooth exposure at rest that is not possible to see now, teeth. So we have to correct the wrong inclination and worn anteriors. But the first step that we have done at this point is that to create digitally the final outcome. Preview what will happen next. So you see, now we have the cuspids that are positioned in the lateral incisor position, in the wrong position. And if it's possible, we believe that it's much better to move the cuspid to their own original position in order to be able, at this point, to give then two implants on the lateral sides, lateral position side. That is what we believe is the best solution. Why? Because the cuspids in the lateral position have to confront with a bigger, very wide tooth size, different than laterals, and normally also apically, we are cervically more apically than the normal lateral position. So the cuspid height on the cervical area is much higher than the lateral incisor. That's the reason why we prefer to move these cuspids on the lateral position. In this way, you see here that the lateral were now changing position. You can see digitally. And now we have a position that way. And then you see lateral incisor now ready for implants. At the meantime, we have to position down grafting with the orthodontic surgical procedure to create better kind of situation. We choose this situation here. We improve it, the occlusal plane. That was like that before. It was moving into that, more flat, less curved speed curve. So in this way, you modify as you like it. Orthodontically, the first step was ortho pre-surgery. In this case, we also put more in the upper anterior and the upper jaw, actually because it was too inclined, was inclined that way. So we have to reduce the inclination, and this way you can become even worse. At the beginning, you have created a kind of reverse occlusion. reverse occlusion, but at the same time, what I said before, we try to position the cuspid in the lateral position, so the cuspid in their own position, and leaving the two space for the implant positioning on the lateral incisor. So, at this point, the second step is maxilla advancement and down grafting. After having done some ortho to reposition more lingually the buccal part, at this point we have doing this kind of maxilla advancement, so the orthodontic surgeon with down grafting, and that is a combined treatment. At this point, the first step is now the post-surgical orthodontic finishing. Now, magically, after the orthodontic surgical procedure, we have the chance to have an overbite, and the right inclination of the anteriors. We move the frontally all the upper teeth presence. At the same time, we have the fourth step. Now we can position the implants in the right position. We do also some kind of cryo-lengthening procedure because we had the situation that was altered passive eruption in the posterior area. You can easily see here the level of the enamel underneath that was covered by the gingiva at the beginning. So now was because 8 weeks control, you know, is not special service over there. We have the situation over there. We have ideally lengthening the cervical area of the cuspid. What happened? Lost signal. I don't see. I can go ahead here, but it is no. I don't know. The technician here there? If I remove this, I can just work with this the finger. No, I understand, but you move it there. Okay? No, this is no that tiny is little one now. No, it's the entire. Ah, okay. Let me check. Yes, okay. Thank you. Anyway, we have to wait a little bit more to achieve the best result in terms of recreating better papilla that is not perfect. At the same time, we increase the length of the cuspid in order to have the lateral incisor, as we said before, in the ideal dental composition within this line. So this is shorter than cuspid and central incisor. So that is the final outcome. And now here is the prosthodontic finishing, ready. So aesthetic function is also very, very important, actually, because you have the situation under control in that way. So we guide the patient in CR, the dorsal maneuver, is touching in that way over there. So we then the crucial adjustment in the internal incline of the upper teeth in this way, without touching, of course, dentin, just keeping an enamel, stabilizing the occlusion. It was sound, not. So it was saying that was, you cannot hear it, but actually it was saying that the occlusion now is much better than before, once you put the patient in CR doing the occlusal adjustment. Now, post-ortho occlusal refining was done, and at this point with the mock-up, we did the final mock-up, and we tried to have a calibrated reduction, to have the preparation made within the silicone index that was derived from the mock-up that we have done before. At this point, we have the fifth step, the prosthetic finalization, and actually we have now enamel everywhere on the abutments, natural abutments, and the two implant and the two lateral incisors. At this point, we have this lithium disilicate that was selected as final material. We layered completely the incisal edge to have the better effect on aesthetic result. That's the final work in the stone model. X-ray is showing the nice result that we have obtained with the two implants. And that was the final work. That was much different than the one the year before. So in this case, we can say once more what you've seen before. Ideal dental composition, ideally for our patient. Incisal edge positioning. Lateral incisor between the two lines that can be traced by cuspid and the central incisor. The two lateral incisors are within that. And interincisal angles in embrasures that are really wider and wider from central incisor to the cuspid. That is, again, a kind of stereotype solution that I don't like so much. I would like to be a little bit different. Maybe lateral incisor a little bit turned a little bit down. But the patient doesn't want. When they start to say, to accept some little kind of inclination, they say, yes, I like it, it's more natural. Then when you come to me and they say, yeah, lateral, it's a bit tilted. Yeah, but we agree already. Yeah, but I don't like, I thought that was better. You know, they're never happy if you don't have the perfect right and left specularity. That is the limit that sometimes we have it. But that is what the patient wanted. So again, all the steps that we have discussed already as ideal dental composition can be found here. And once more, that's the reason why the patient loves it, to be within this kind of situation. Now, before and after situation, mosquitoes is taking care about me. Actually, and then you have the multidisciplinary approach with the 5 level of intervention, before and after, with a big kind of improvement, thanks to the ability also to the surgeon that did a great job in terms of, advancement of the mandible, of the maxilla, down grafting. Now let's talk about MAPP 2B. 2B, it means that we have a full veneer. It happens to have a full veneer when you, after the occlusal adjustment, are not able to have touched all teeth. You have an open bite sometimes, forming on the posteriors. At this point, you have to close that with a kind of full veneer that we explained by the way now. Claudia is coming from South America. She wants to be aesthetically pleasant, but at the same time, you see at the rest position, no teeth exposure. Rest exposure is nothing, zero. So you have to shorten it. I mean, you have to lengthen the anterior upper teeth. At the same time, what about the function? We ask the patient to move, and you can see there is a loss of anterior guidance. So, you see, we have also, when you guide the patient in CR, even though the definition of the CR is the most antero-superior position within the glenoid fossa, with the condyle in the right position, most of the time you have a slide down forward of the mandibular situation, the mandible. And that's the reason why when you guide the patient in CR, you go back, not anterior, but going back, clinically speaking. At that point, you have to check, this point is opening a space over there. And without preparing the teeth on the palatal area, you can extend the buccal veneer to the palatal one. As design, of course, is a kind of a crown. I don't think that his name is crown, because crown is when you prepare the teeth. So it's a kind of full veneer, an extended veneer on the palatal part. That is the way how we do it. At this point, we have to extend the final work to the palatal area. Then you use the calibrated reduction. You can see that we are within enamel 100%. We prepare the teeth. We can see that the preparation are less conservative at this point, 15 years ago when we started to do use case. Even though we have white appearance, means that we have a lot of enamel over there, almost completely enamel. The lingual part was not touched at all, practically just tiny bit dentin present there, already in the past. We did the 6 full veneers, full veneers. It's not a crown, it's a crown design, but a veneer heart, as you could say. So that is preparation are within the enamel. Then you apply this kind of place that was an open bite here. We can really overcome over this, not touching the palatal part, just adding some kind of etching procedure that you can etch with orthophosphoric acid, and of course the veneer with hydrofluoric acid. So that way you have really an etched solution. And the thickness of this restoration will be between 0.2 to 0.8, minimal one, to keep enamel properly, in the proper way. So we kept this enamel present there, completely in enamel. That is the way how to really be careful, to be able to really let the result will be maintaining the same one over years, as you will see in this case. Full veneers in place, and again, anterior guidance now is showing the disclusion of posterior teeth through the anterior guidance. So you can see the cuspid guidance right, left, and the frontal guidance, incisal guidance, discluding the posterior teeth, creating less problem on the function, of course. Now functioning well, anteriorly. 6 years later, look at the good, nice maintenance of the aesthetic, at the same time the blending between the back side and the other side. You can see 8 years later, still maintaining the same position. Again, nothing changed. Also the parietal view, cuspid guidance with natural teeth, anterior guidance by the restoration we made, the full veneers. 8 years later, nothing changed. 12 years later, nothing changed either. So maintaining the same one, still discluding the posterior teeth during excursive movements. And the time is passing. The time is passing is proved also by the patient picture that you see that is, aging a little bit. Of course, that's normal. So still there, nothing changed. What about another case of MAPP2B? Full veneers in place. Look at this lady. She had a palatal cleft, and she had the chance to be in some way treated by the orthodontic surgeon, Mirko Raffaini from Italy, great surgeon. So that was the kind of framework positioning with the maxillar advancement. He also did some little differences on nose, lip, differences. My voice is going on and out, maybe? Okay. So orthodontist was Renato Cocconi, very famous orthodontist in Italy. They did all the work done. At this point, they sent to me the patient to do what? To do a lateral incision, right side, implant there. And that was, big hole, big space over there. And they asked me and my team to do something good to finalize the case. Not easy at all. We put the initial Maryland bridge, and then I asked Eric Van Doren and Stefano Gori to follow me on this kind of adventure to finalize the case the proper way. We actually have the situation under control now. We have created more bone and more soft tissue in that area. And once it was passed a period of time that it was approximately 3 months, I started to do the provisional and to condition the soft tissue during the healing process. So healing process was nice at this point. I tried to refine the provision in a proper way, also to, in some way, finalize it with the glaze and the color, and positioning the patient mouth, pushing delicately, not having ischemic reaction for minutes, but just for seconds. And that's the way I did it, with the big change between the before and after. Thanks to the ability of the surgeons, and also to the work that we have done in the proper way on, in some way, conditioning the soft tissue. So now it's completely changed. Everybody happy, the orthodontist happy, the orthodontic surgeon happy, the parents of the lady that was just 21, very happy. But not the patient itself. The patient was not happy at all. Why? Because she was saying to me, "Doctor, I don't like my smile. I don't like my smile. I like the provisional that you put in me in the mouth. Papilla height is still okay." So it was almost a miracle, considering the starting point that we have on that situation. But looking at her, you see the situation. She said, "I don't want this male smile, very square teeth. huge central incisor, quite flat inside the ledge. You have to have a organized approach, of course. So aesthetic concern, one missing tooth, but she didn't like at all shape and contour of the teeth. She want to change it. And there is any reason for that? We want to see at this point what happened next. We have seen at this point that we have one tooth that is bigger than the other one, changing. So she was right, she was something wrong. Very square teeth, but even different size. So we convinced the parents to do some little modification also cervically with a minor surgical procedure with a gingivectomy with internal bevel to move it to, again, be in the parameters we have seen, aesthetic parameters we have seen already before. So that was now the situation with the cuspid in the right position, also cervically, lateral incisor in the right position again. Yeah, just to renew all the anteriors in a proper way. So again, aesthetic function here. We put the patient in CR, guiding the patient. Look at the slide, huge slide between CR and MIP. That is normal when you do this kind of huge orthodontic surgical procedure. You cannot never be perfect after this kind of enormous kind of change on the maxilla and mandible situation. So occlusal adjustment was done within the enamel, of course, on the incline, not on the cusp tip. And we have the opening space over there. So the new provisional, the new setup that has to be done in that position, stable position in CR with the extension of the buccal veneer to the lingual part, creating this called full veneers. Okay? Occlusal refining, once more. Look at the difference between MIP, acquired position, and CR. We put this kind of reorganized approach in CR position. It means that now we prepare the teeth just buccally, making enamel everywhere, but because we have the space on the lingual area, the palatal area, we have to reverse this preparation on the lingual. And the lingual area, you can see, is still not cleaned, is dirty. Why? I want to show you that you don't need any kind of technique that I have with two veneers, one on the back or one on the lingual. That is quite fashionable today to do it. I don't see any reason why to do two veneers instead of one. Back and lingual doesn't need. You have just one that is two pieces together. It's just a crown design by full veneer art, as I said. So at this point, I show you the palatal part was untouched for purpose, just to show myself and to show you guys also that even though you do the full mouth restoration with the full veneer, even not preparing the lower, the palatal part, even not touching at all, as you have seen here, we take the impression and you have the ability to actually create this kind of situation that is completely, perfectly done. You see that it's not touched at all. I give you the CR position with the guidance, temporaries, that the guidance, the right side, left side, so that the guidance obtained in a proper way, clinical test on that. You see the extension between back side to the lingual side. If you have undercuts, you cannot remove the wax without breaking, without break. So actually, in that way, showing that you can have the chance to see, in this case, you have the possibility to have a full veneer even though you have not prepared the palatal part. What is important is you can see also, you can stop your restoration. If you have undercuts, you can have the last part of this palatal part here. But you can also stop your occlusion up to the cingulum. In that way, you cannot, for sure you have no undercuts. You cannot stop here, because every study is showing you that it's very delicate, a fragile position over there. You can stop over there on the cingulum. You have no undercuts because this part can be the only one that can be risky for undercut. But you have not done in this case, for example, because you have removed the wax, it was completely stable, not broken at all. So you can try, and then if you are not able to arrive up to there, you can arrive up to the cingulum. That's to avoid 100% to touch the enamel. Of course, you can touch slightly, keeping the enamel 90, 95 or 100% in place. You can maybe is the thickness of the enamel, but still present there. So the key point is the presence of enamel, of course. You have to do everything to avoid the absence of the enamel. You have to keep enamel as much as you can. So square situation are to be changed in more rounded as the patient requests. They request to have a rounded situation. And that was the final work. Rounded as the patient wanted. That was modified as the patient loved it. You see how was nice the final result in terms of both anterior aesthetic result and also cervical area that was comprehended with the two papillas, not exactly the same level of the real one, the left one, but still very acceptable considering the initial situation that we have seen before. That was really difficult to keep it. So right side, left side, very nice result. The patient was very happy, changed completely her life. And also, it came from this to this. And once more, within all the steps that we've seen already, I don't want to repeat anymore, of the anterior dental ideal composition, just to show you once more that if you are within the limit, you have successfully finalized your case. And that is how they move, how she moves. Perfect, moving well, no problem at all. And that is showing us that working well, and that we'll be confident that the result will be over years very well. So that is the case after 7 years in service, and the patient growing up. You can see that is better view than before. She's more happy than before. So now we go to MAPP3, that I really call the MAPP3 the prosthetic revolution. I want to say we did some case like that in 94. In 2022, we are still working there, leaving the occlusion as it is. Actually, we lose the voice. I cannot turn myself. Okay, that is the occlusion that was changed completely, remain identical. We have some kind of preparation that was subchangeably already on the back side, on the lowers, but on the upper we have some recession. Not nice, but actually is possible with a periodontal biotype like that is thin like this. And when you have, work with this patient for 27 years, so it means that is a long time ago. But what we don't like is not just that, is the other side, is this one. Look at this, look at the upper anteriors, lower anteriors, both of them. They have the chance to see, they're blocked now. Okay, they are actually walking there. You see that we have devitalized all the 12 teeth, 6 upper, 6 the lower. That's crazy. Why you did it? It's a long time ago. So what we do today, we know the classic approach, doing endo, metal post, crown lengthening procedure, preps that are very aggressive, and using metal ceramic. Today, with innovative solutions, you can have the modern approach with the pulp vitality maintenance, addition with minimal preps, and using also ceramic restoration. We publish different articles in these kind of topics, and the topics that were mainly on the, also on the classification, but mainly on the MIPP3, that is the more evolved. And actually, that is valid when you have to deal with the kind of worn dentition, especially with attrition, especially with bruxing activity. Remember Max, the golf player? You have seen this morning or at the beginning? Again, he was talking, not showing teeth, but the teeth were underneath. Why? Because he was bruxer, big bruxer, was really, destroying his teeth. And how far they are from the ideal? Very far away, very far away. In this case, the bruxing activity, as you can see, can have a double kind of value. The awake one and the sleep one. Awake one is when the patient is during the day, is clenching. 20% of the population seems to be affected by that. They clench all the time. The muscle can be pumping here. You can see the muscle tears pumping. You are on that situation. or the sleep bruxism. Sleep bruxism is a kind of sleep disorder with the microarousals, 8, 14 times per hour, according to Lavin, Jesus Lavin showing this. And actually, is a kind of rise of autonomic cardiac respiratory activity tends to be repeated 8 to 14 times per hour. Is mediated by the central nervous system. So the occlusion steps seem to be not so important on that in anesthesiology. It's a long story. We can short debate about this for a couple of days at least, but we have no time to do that. Just to analyze the case that you have in front of you. This guy is affected by attrition, for sure, yes. And epidemiology, we can jump away this part, but anyway, there's no difference between the sex. Great variability from 6 to 91%. Only 23% of the patients are aware they are grinding during the night. As you know, your husband or your wife, you know, you can understand it. They are grinding during the night, but the patient that's grinding doesn't know that. The company and companions say that, but not them. So let me fly on that. I want to just tell you, the key point of MIPP3 technique is the alteration of video. A video should be considered, it was considered on the past, a fixed, inalterable position. But at this point, we know that it's not like that. You have a dozen articles showing the difference. In this case, for example, we have increased the video. We have a short teeth. We have lost not just length, we have a short also big part of volume of the teeth. And we need to add volume. And the proof of that is the wax-up. The wax-up in blue is covering completely the white that you have underneath. Means that you have not cutting the teeth, because the mock-up is something that has to be reversible. So you cannot cut the teeth to obtain the result of the mock-up. The mock-up is there because you can have an adding procedure, reversible one. The patient doesn't like it, you remove the mock-up, and we are not treating the patient if you not agree. But it's the way how to convince the patient to do it, but it's a reversible step. So allow you to achieve some kind of preview of the patient without touching the teeth. That is the case. That is the case because you have to lengthen the teeth, you have to add volume, as I said. So we have increased the video, we have put inside the wax-up all the aesthetic functional parameters, as you have seen already with the lab chart of my book, or in GitHub, that is the application that you have seen, just rapidly, is an additive wax-up. And at this point, you have increased the video according to the clinical needs. Many people ask me, how much you increase the video? Depending on the clinical is important to add. How much the technician needed the space to build up teeth without cutting the teeth. So in this case, we have increased 6 millimeters, even more. It's quite a lot in this case. So again, what we need, how to inform the technician what to change since the beginning, since the initial case. So we have to detect, to decide, to analyze where should be the incisal edge position from the frontal view, from the lateral view, both sides. At this point, you have to do that for the upper and lower incisor. Then, orientation of occlusal plane. Again, you should have the occlusal plane that is oriented according to the horizon, At the same time, you want to say how much to alter the video. You want to alter and how much. What do you need clinically. And then, occlusal posterior stability CR, that is very important, you said. And last but not least, also the anterior guidance with exclusion of posterior teeth, of course. All these are something that you should communicate to the technician in order to be able to finalize the case that way. So our suggestions, indications for dental technicians, that they never receive so many information, unfortunately. That's the problem. They are not magicians. Many times when you are in trouble with a patient, say with a provisional that doesn't like too much, don't worry, my technician is great, he's a giant in his work, can do great job. But they have to invent. They shouldn't invent anything. They should be able to receive a lot of information. of course. So in this particular case, we did the mock-up, but the mock-up is, again, is the summary of all the aesthetic and the functional parameters that were put inside in order to optimize the case. It's not done by chance, I will try. You try nothing, you just know in advance what will be the final result. We just want to have the possibility to, in some way, achieve the result that we wanted, having the chance to know in advance that happened. Because actually, you know that we put all the aesthetic and functional parameters inside. Now I can speed up the movie in this way, but then with the silicon index derived from the workshop, of course, we can put inside the acrylic inside, bis acrylic, upper, lower, and then you close the mouth, you should have the same result that you wanted. That upper, lower, eyes are still not thinking what happened next, but at this point you see that the perfect in occlusion. We just touched just tiny bit in occlusion, and not aesthetically any kind of changing. This was needed, not needed to do that. Was already perfect because we have sent to the dental technician perfect information. At that point, the patient starts to see it himself. Finally, he never showed teeth before. Now look how happy he is now, because he found the way, even when he talked, to see some little part of the teeth. Inside we have added more than 5 millimeters in length, just to tell you how much. So all the question is, it is possible to change. What happened when you increase it? How to decide the amount and how to test the increase. All the questions have the chance to be, of course, answered positively. First of all, why you increase the video? The main reason is the space for your restorative material. Means that you can really prepare almost nothing, especially occlusally. You can rectify, if needed, all the occlusal setup. You can rectify, if needed, all the functional setup. You can avoid any kind of endodontic treatment, any surgical clearing procedure, and post-in-core material. Big advantages. So, Abdu in 212 showed this article, 908 patients. And in that way, you have, whenever indicated permanent increase of the video, up to 5 millimeters is safe and predictable procedure. Just in case you have some kind of problem in terms of signs and symptoms at the beginning, they were self-limiting with the tendency to resolve within 2 weeks. That was nice because it's a kind of, again, review article that was saying many things. What about also Jeffrey Okeson? Some people were talking about some possible problem on TMJ. But what it happens, and what is written in his article, Jeffrey Okeson is one of the most important on TMJ situation. The stomatognatic system has the ability to adapt rapidly to moderate change in video. So there is no indication that permanent alteration in video will produce any kind of long-lasting temporal mandibular disorder symptoms. So that is an article that we published just 1 year ago. With my group, we had the chance to have 100 patients, not 1, not 10, 100, big number. And of course, we did it. Video increment that was approximately 3.3 for natural dentition, 3.6 for mixed supported, and 5.4 with implant supported. Because the implant, when you have no more teeth, will be more complicated to know how much you have to increase. And you can have, a big amount many times of an increase. But anyway, 3.5 is the average, more or less, on teeth. So that is important to have it. And what about happen? What about the adverse event within 2 weeks? One of these problems you have to encounter? And especially, you have this problem with every patient you treat? Among 100 patients, how many patients have problems, one of these problems? According to our research, only 17% of people were affected by this problem. 83% of people were saying, I feel comfortable 100%. Nothing changed before and after. So that is a very important step, to know that most of the patients have not any problem at all. Article by Hammond that can create this kind of solution. Also try with less number of patients. It was having the chance to have only 5% having some kind of sensation that we have something happens. Anyway, on the 17%, the people that have some concern, which one is the most important one? As you know, we discussed just slightly about that. S sound is one of the problems. S sound was one of the problems. As you can see from this picture here, we have S sound as a problem. 7 of them, among the 100, have the problem of speech difficulties. And then other stuff was showing difficulties, normal to say. But after the weeks, between 2 and 8 weeks, you know, the symptoms decrease. Only few people, just one person still talking about S sound. 3 people talking about the muscle and joint fatigue. Takes more time sometimes, and that happens in this case. So, but the last control, 0. So everybody succeed. So, first question, can you do it in every patient? Practically yes. So, what about the parafunctional habits? 44% of them, when they come to the studies, were affected by parafunctional habits. After the finalization of the work, only 17%. So means that not a new diagnosis of parafunctional habits activity was happened, and only 17% was still Braxin. So just to tell you, video increase is one very important key point that has to be remembered. So remember also, mandibular position. We discussed already. We left this situation here. When you have to do full-mouth rehabilitation or dentition like that, you have to increase the video. You have to put the patient in CR, and together with that, we will have this kind of solution. Box up, that is derived from that. So, with the positioning of the video, the new height between the two arches, according to the clinician needs, plus the position on CR, that is very important to recreate the same kind of steps over time. The patient starts with that, in this way, without having any teeth at all. Seem to be not teeth present there, but as soon as you have the mock-up in place, will be completely different. At this point, you want to cut the mock-up. I want to keep anteriorly the mock-up as it is, because it can be fixed in a proper way. You have the full veneer, is a crown design. So at this point, it will be very possible to maintain that position. I want to cut the posterior area. We do the cut, but look at the cut. Before cutting, remove the occlusal part. You see the thickness that you have there. So my question is, do you really have to prepare the teeth? Can you prepare? Are you crazy? You don't have to prepare. It's already oversized the amount of thickness that you have at your disposal, because you increase the video. It has a nice picture to understand, to remember. I don't want to cut. I want to just refine my margins with the burrs, but not reducing the space. I mean, augmenting the space that you don't need it. It's already enough in this particular case. In other case, will be less, depending on the case. But the key point is to keep enamel for bonding procedure. That's the key point. So you see, you still can maintain the occlusal pattern as it is. So we then did the provisional perfectly there. We optimize the occlusion, we optimize the aesthetics, and then we communicate to the lab what we have done for posteriors. We take the impression of posteriors. Okay, so final impression of the upper and lower posterior teeth, Facebook taking, CR record, protrusive record to set up the corneal guidance on the posterior area, and bite record of posterior mock-up and preps Alternatively, in order to have this kind of called cross-mounting procedure. Okay, in that way, I show you mock-up in the upper, preparation in the lower. That is one bite record. Another one is on the opposite, preparation in the upper, mock-up in the lower. And the third one, preparation as preparation. The same height. In this way, you copy something. You don't have to fight with the patient that say to you, the provisional is different than the final. In this case, you copy that. You change just the material. That's all. So that is the removable mock-up, as you can see here. Just to repeat, option 1, you cut the teeth on the upper jaw. You take the bite record between the upper teeth repair and the lower mock-up. Second step will be the opposite, keeping the mock-up in place on the upper, posteriorly, and prepare the lower. And then preparation against preparation. That's the 3 points. And then you have this situation here, you put a provisional in place, and then you finalize the case, final restoration in place. Now, once you have stabilized perfectly the anteriors, at this point you go to the anterior, the posteriors, you go to the anteriors. So posteriors are already there. You have to cement it to maintain the position and the height between the two arches, so the VDO and the CR position. And then you prepare the anteriors at this point. Again, you see the enormous amount of unsupported ceramic that you can see here from the shadow. You know, that is unsupported, that is the abutment underneath. Abutment underneath, unsupported ceramic. It's very risky. It could be risky theoretically, but that's the situation. You cannot rehabilitate the patient without having the normal length, normal size. Calibrated torque reduction, you see how much you have to increase the length. That is the amount to have some little visibility of the incisal edge at the rest into the provisionals. So, untouched structure, 5 millimeter distance there. Palatal part will be not prepared at all. And that is the point. Lab communication for anteriors. At this point, final impression of the upper lower anterior teeth, the posterior already done. Face bow again, CR record, protrusive record, and again, bite record between anterior posterior mock-up and preparations, alternatively, a cross-mounting procedure on that. So again, you went already finalizing the final restoration with the white color over here, then you start to prepare the teeth anteriorly. We are stabilized by the occlusion on posteriors, and we can prepare anteriorly, first of all, anterior preparation on the upper against the mock-up on the lower. Second one, the opposite, preparation on the lower and mock-up on the upper. Further options, third bite record is between preparation and the preparation. And then you put the provisional, and the next step will be the finalization, finalizing the whole work, upper, lower. So what are the advantages? Easy bite registration, less stressful appointment in comparison to have done all together in one step, in one spot. Disadvantages, more appointments, difficult provisional management during the time. So, enamel preservation. You see that on the back side, we left the cord visible. Why? Because our final outcome will be up to the CEJ, not going up to the margin over there. We don't need it to go there. I want to arrive up to here because later on, if you want to cover with the soft tissue, this area can be still done. On the palatal part, I didn't touch at all. I kept the enamel everywhere except these areas that are indenting already. But all the enamel that was present there was maintained completely. 80% at least, plus 95, 100% on the back side. You have a big kind of retention of this. So the initial case, that was like that, biological integration, we prepare minimally, just keeping the enamel where it is possible to keep it. Enamel preservation is the key point, as I said. Look the length that we have added. Enormous amount. To have 11 millimeter length now, having some show at rest. So, with the posterior in place already, that was cemented, bonded properly, now we have finalized the anterior, ready to be positioned in the patient mouth. all the anteriors in place, and that is finalization. CJ is the preparation border that was left here, not checking this area, was said at that time we will do next, but the patient didn't want to do it. But there was one simple reason. And the reason is lose my line. The patient didn't show. So why to do it? I can do next? He said, yes, of course, you can do next. But he didn't do it. Up to 8 years in service already, but he didn't do it. Can keep it like that. You see that it's maintainable. We also have create a very nice management of the space, also on the posterior area, with the diastemas, without doing any ortho, just prosthetically done. And lower arch, again, look at the difference, even in this case, between the length, the total length, and the length of the abutment. And you can see that, calibrated reduction. And very difficult to close the diastema without doing ortho, but in this case we did it properly. That way we have the chance to optimize the case anyway. But I want to show you my best picture. That is, you know what? The mock-up of the guy, of Max. It's not well refined, it's not completely refined, but just to show you how easy it's possible to really achieve and to copy the provision to the final. That is the perfect case to show you. Take a look about the picture right now. Look at the transformation between this to this. In this case, the same position, same length, nothing changed, 100% copy. That's to show you that it's possible to copy 100% of your mock-up. If the mock-up is well done, if the mock-up contains inside all the information they needed to put inside to your dental technician. That's the point. So lost my line. That's the reason why we didn't care about the recession on that area. 8 years later, still working well. The recession is there without any problem. At this point, again, each case I finish with the full mouth rehabilitation, even 6 and upper anteriors, I do a little movie, 20 seconds, just to show myself and to the patient, working well, moving easily, not having a kind of restraint or, you know, of a problem of moving. Let me show you a very complicated case. Sjogren's syndrome. That is the first case I did with my technique, the MIPP technique. She has a lot of distraction. You have no saliva practically. It's an autoimmune disease, Sjogren's syndrome. So this way can create a kind of a pH that is very acid. pH is below 5.5. Very problematic situation. A lot of dentin exposed, but not always, not always. They did some compound that was infiltrated. I want to show you what they've done on this case. We increased the video. It was a little bit shy at the beginning. I didn't increase enough. Then I increased more, 4 millimeters anteriorly in the CR position, of course. And then I increased 3 millimeters totally, not so much, between the two arches. I don't need more. So what to say about minimally invasive procedure? Maintenance of tooth structure is, of course, the key point. You have 3 steps. Increase the video, reduce the ceramic thickness, I'll tell you how, and last but not least, enamel preservation in order to have bonding procedure. That is our goal. So first step, increase video. What we say is the following. If you increase 3 millimeters anteriorly, follow me. You have space, divided 2 is 1.5 millimeters each. If you go to the worst scenario, that is the last molar, the second molar, you have minimum thickness over there. Is between half size. It will be 1.5 instead of 3 millimeters. So 3 millimeters here. On the last molar will be 1.5. Divided for 2, you have the average of 0.8 for each arch. Now we have to ask you, do you think it's still available, having 18 millimeters instead of 1.5 or 2 millimeters, as many people said, and many books and leaflets said? I strongly believe it, depending on the kind of tooth structure the knee. Dentin. Have you enamel or have you dentin? If you have enamel, I would like to keep enamel 0.8 because it will guarantee to me very incredible adhesion. So I want to keep enamel as much as you can, reducing the preparation thickness. That's the point. If you have just dentin, of course I cannot do it. But if you have a part of enamel, at least 30% of enamel, I will feel comfortable 100% of my cases. Okay? So that is the point. 0.8 per arch should be more than the necessary. So reduce ceramic thickness. I want to tell you something more. On that field, I would say the company that produced lithium disilicate, that is called Emax, is Ivoclar, as you know, they suggested to have 1.5 millimeters, you see, on occlusion. I said, you're crazy. If you have enamel there, you destroy it. You remove it. You do worse. You don't improve. You worsening the effect. Because if you have 30% of enamel, 40% of enamel, you cut back, you exclude all enamel. You are dentin at this point, everything in dentin. So I was fighting with them. I was saying, you're crazy you do like that. Until last year, they came with a different solution. Look now. Now they decide to have 1 millimeter, no more 1.5. They understood, finally, that is crazy kind of a concept that they were following. 1 millimeter even too much. I would like to say, if you have enamel 100%, like you have a tabletop on enamel 100%, I can always having also a thickness of 0.2, 0.3. Even less than 0.8, 0.5. Even 0.3 is possible. So maintenance to structure is the big point, the big goal. Enamel preservation bonding procedure is the next step. Even if you do full veneer like that, you can be 100% in enamel. You can be 100% in enamel. So enamel preservation is the key point. And again, remember, full veneers is like that. Increase the VDO, you can create space between the posterior area, and you have close this space, this open bite, with the etchable ceramic with etchable enamel. We can create a kind of sandwich that can create an important kind of retention. About full veneer, there was also an article published by Edelhoff Group from Munich. A full veneer restoration in the interior area presented 100% success. Our results are exactly the same. 100% success of full veneer restorations. So articles, of course, anteriorly, you can have the monolithic area. Monolithic are obliged to be done on posteriors. I don't want to have any kind of layering process on anterior or on posteriors. You don't need it. Aesthetically, it's already very beautiful anyway. So anteriorly can be some reason to do that, but not posteriorly. And there is a very interesting article by Petra Guess that was published a few years ago, saying that 0.5, not 0.8, even less, 0.5 millimeter, exhibited significantly higher failure loads as the supporting tube structure is predominantly enamel. That's the point, predominantly, more than maybe 40, 50%. Even 0.5 is okay. But if you cut more, you destroy all the enamel, you have just dentin. At that point, if you have just dentin, you have to go back and prepare 1.5 or even 2 millimeter occlusally. That's crazy. I would love to keep enamel if I have it at the beginning, not destroying completely. So I want to show you some kind of steps, clinical steps, like that. 1988, that was my preparation. I made in 88. That was the new preparation in 2008. 2008, 20 years later, you see that was the same lady with the Sjögren syndrome. I rehabilitated with the composite all the teeth that were destroyed to then take the impression as normal full veneer or crowns. Some enamel, some dentin, mainly dentin, 40% of enamel only. That was very complicated case to be treated. I was aware about it, and we discussed together with the patient that is an anesthesiologist from Stuttgart in Germany, and we discussed. I cannot guarantee to you any kind of final result for a long time, because you have the pH that is very low. Acidity of your saliva, minimum saliva, but it's still very acid. It's complicated, but actually we see the case over time. We prepare the teeth in that way. So even though the 208 seem to be less prepared, in 220 you see that are prepared teeth seem to be prepared that way. That seem to be ideally prepared. Seem to be not prepared at all, but they are prepared, minimally prepared. Minimally prepared. Some open space where you have old composite that we have created. So on the upper jaw, we have done partially layered on posterior monolithic. Same one here. Partially layered anteriorly, monolithic on posterior. Initial case, final case. That was at the time of delivery. Of course, time of delivery seems to be interesting to know what? Another kind of important step. X-rays. Final X-rays. Have you any decades underneath? Anything any devitalization? No one. Zero devitalizing teeth. That is a super result, in my opinion. Because she came after having visited 7 different dentists between Germany and Swiss. Everybody said devitalize all teeth. You have seen the beginning situation. Could be possible with the traditional method one, but if you want to be more modern one, you can keep it that way. Yes, you can have a risk. What happened next? What happened in 1 year? What happened in 2 years? I want to show you the occlusal stability that we have achieved, the anterior guide that we have created, the better aesthetic result that we have achieved again, improvement, right side, left side. But I want to show you the case 14, not days, years later. And you see that everything remained practically unchanged. We had just tiny bit kind of recession of the central side there. Nothing, zero. That is clinical setup. What about patient? That was the time of delivery. Can you please put the sound? Sound? No sound.
We were, together for many hours and many days.
Yes.
But, you do normal hygiene recall,
That's the time of delivery.
That's what I
Time of delivery. But then you can say,
10, I would say wonderful. It feels
that's 14 years later.
teeth, so
So no pain, no inflammation, anything?
no, I don't think in the
No pain, nothing, zero.
Yes,
14 years later.
yes.
So can you give us a nice smile? Real.
Maintenance, 14 years later, with the problem that she had already. And actually, that was the situation, 14 years later, occlusally, perfect in occlusion. Then, upper, before delivery, and 14 years later. Some stain was removed, maybe by some occlusion control over years, that I did it, of course, or some stain that is a superficial one, that is, of course, going away. Upper, lower, same things, identical. Picture, X-rays, even more important. No devitalization at all, zero. Zero was a nightmare for her. She changed seven dentists. Everybody want to go to do all the devitalization, all the steps. Other case was made at the same time, 208, 14 years later again, before and after. Again, not devitalization except the second molar on the left side, but that is for other reason. So, anterior guidance. So video increase, again, central relation position, anterior guidance, as enamel preservation, reduces ceramic thickness, and bonding procedure. 14 years later, it is the case too. Look at this, identical practically. Another case. What is changing here? Time of delivery, 14 years later. Some kind of worn out on the cuspid guidance. Of course, the patient is still alive, so it's working. working on the cuspids. Disclusion on posteriors. So what about tips when you use this kind of ceramic material? Integrity. Use monolithic material on posteriors. What to say? At least on posteriors. Probably it's better to use all the time. If you don't care about incredible aesthetic effect on the sidal third, that is perfect. Keep as much enamel as possible. Keep as much enamel as possible. Third, use a predictable bonding procedure. Golden Star, the 3 steps, in my opinion. And last but not least, even though brushing activity is not related to the occlusion, please don't forget, create a proper occlusion pattern. That is a very, very important point. That is a graphic of the research that we have done just a few months ago. 45 patients, 87,040 restorations, long steps. Look at the restoration type. Okay? Women, men, monolithic, layered. Bob is buccal occlusive veneers. I show you what is Bob technique. Bob is buccal occlusive veneers. You have to increase the video, so you put some tabletop. But the tabletop is extended only on occlusion. If you want also the aesthetic result, you can add from the back, from the top, also the back side. It becomes one piece, buccal occlusive veneers. At the same time, you take care about occlusion, increasing the height, the video. At the same time, also optimizing the back side of the aesthetic side. That is the reason why we define the buccal occlusive veneers. Posterior restoration, anterior restorations, you see all the percentage. What I want to tell you, failure rate. We had 9 failure on posteriors and 0 failure on anteriors. So the Kaplan-Meier analysis was 99.5% at 3 years, up to 10 years in service, 96.5%. Very great result among more than 1,000 restorations, among over 87 arches. So that's the reason why we did a lot of cases. I can show dozens of these cases, but the concept is the same. Increase the video, and having the chance to follow the steps that you have seen, before and after. 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 All the same. Nothing changed. The concept is inside there. Last case, I want to conclude my presentation. She's from Romania. She's engineer. She was working in order to be possible to have a gas tube underneath the Black Sea, as I understood, in a way. And that was nice, because she wanted to, as a treatment formulation, short teeth. She was just 33, and she had short teeth, yellowish teeth, all the Get Up solutions. In this way, as we said, the works up derived from Get Up. The mock-up was in place, testing, not just in occlusion, but also in disclusion, removing the all posterior interferences. And that is occlusal stability, that is a kind of posterior disclusion. We have the length that's short, that was less than 8 millimeters, becoming 10.7, almost 3 millimeters of increase. Video was increased 3.5 millimeters, again. Overjet was increased through the position of the central incisor on the upper jaw, that was obtained more space after occlusal adjustment in CR. The overjet value, as I said already, is absolutely a key point that allow us to be more positive on the long-term result. Preparation. That is before preparation here, after preparation. We open some space over there, just in case you have some old composite, or just in case you have some kind of brownish decalcification among the teeth. Open the space over there. On the other case, we keep the point, especially on the lower arch. We have left more mainly over there. That's initial. that is the final tube reduction. That is not reduced at all practically on that, just positioning over there. Just a couple of places where you have the chance to go through in order to have opening the space over there. And that is the back occlusal veneer, the above, as I told you already. That is the tabletop that was needed to increase the video. But then you extend on the back side, the veneers is also called veneers only, is actually you like it, but it's just to optimize the occlusal setup and the video increase, plus adding also the static result. It's one piece with the two kind of value inside. And that is the contact point can be partially removed or maybe maintained completely. So this is a kind of oblique insertion in this way, oblique insertion on the bulb. If we try to use the rubber dam as you like it, you have to check that you have enamel 100%. So when you have enamel 100%, your result over time will be incredible. Will be like a new virgin tooth. If you have enamel 100%, you will be virgin tooth for all your life. And you have the chance to have a transition area management of initial situation with the preparation. Become very flat anyway, if you like it, depending on the case. That is the initial case and the final case. So, MIPP. To be 35 years old, it will be crazy initial, not having any kind of visibility of the teeth, upper, lower. That it can become better result, showing tiny bit at least, the lower and the upper arch, finally, at rest position. The smile was improved, more length of the teeth, more out, backally. More out means also that you don't prepare the teeth either. Because you have this position here at the beginning, you have position there, you just have already 0.8 millimeter of enough thickness already. Why to prepare? You have already thickness that you needed. So that is a perfect situation. If you need to increase the width and to improve this aesthetic result, in some cases it's possible, in other cases not possible, of course we do it, because at this point you can also save the tooth structure even more. And then lateral view, and then posterior disclusion of the anterior teeth, through the anterior teeth, and final work done laterally down here 3 years after. The case was finalized already 4 years ago. That's final outcome 3 years after. It means that everything is still working very well. Also, the biological integration seems to be very nice in every case you see. Look at the change the patient had. Different mood, different appearance, different principle behind. Actually, the shape of the teeth seems to be much better already. It's visible, but what is much better is the eyes of the patient. Eyes is what you have inside, the soul. That is the expression of the soul. And to me, it's very important to see that it change completely the personality. Much safer. Is, also smiling all the time. You want to prove that? Look at this. This guy that is going in is the Prime Minister, ex-Prime Minister of Romania. Okay? He was coming to some people, and he was also the lady that was treated, it was very happy at that time. So when they meet each other at the beginning officially, even though they maybe hate each other, they say, oh, I smile. Smiling, everybody smiling. Hi, how are you doing? Nice to see you. Look at there, smiling. But then everybody sit down and become serious. Everybody's serious except her. She smiled. Why? What happened to you? I was so happy for that. I'm also so happy that you can remain with me all the morning. I hope that you have enough information, generally speaking. If you have any question, I'm available to that. Thank you.
Thank you, Dr. Mauro, for your informative lecture. Now it's time for questions. Anyone have any question? My colleague will approach you. Okay.
Hello, this is Mishar El-Ataibi from Saudi Arabia. Thank you very much, Dr. Mauro, for the very amazing presentation.
Who is talking?
Oh, I'm here.
Okay, far away.
With red color. Thank you very much. It is really very charming presentation, incredible results. Actually, I'm concerning about the message that you delivered today.
The what?
Do you hear me?
Yes and not. I understand that the compliment at the beginning, I came close to you, but I didn't understand the next part. Say again.
Yes, thank you very much for a very nice presentation.
Okay.
I really like the before and after results. But I'm really concerning about the message toward the generosity of increasing the vertical dimension
ECR.
occlusion, yes.
Yeah.
And we know all that physics is physics, and the physical laws, we cannot change it too much. So when you are talking about enamel, that's very advantage to have enough enamel to bond for it. But the height of the material, it's almost 70% is the materials comparable to the rest of the tooth. So I was even looking to the disadvantage that you mentioned. You didn't mention that there is a possibility of failures, a possibility of fractures. They are a general dentist here. They are not very experienced like you. So I think we should give them the caution about the possibility of fracture of such increasing of vertical dimension. They don't have the very sophisticated lab that you have it, not the materials. So I think we should be careful as a dentist from our side to follow this technique, which is very excellent and having very...
I catch your,
Yes.
Yes, you're right, actually. It's not an easy technique. It's not an easy goal to be achieved in a improper way. It seems to be that is quite easy as a concept, because I believe the basic concept is absolutely very positive in that, because you decrease the necessity to destroy your teeth underneath. So I believe that I should be do the maximum you can in order to achieve this result, following this kind of technique, because it's absolutely very successful. Of course, the management of all the steps will be very delicate. First of all, we're talking about full mouth rehabilitation. It's, as you know, it's difficult anyway in terms already the concept of full mouth rehabilitation, because it includes many, many steps. For example, CR position, of course, is something that for us is quite normal to use it, to do it. Many people, I'm not talking about here, but at least in my country, don't ever manage the mandible in a proper way. Most of the time, they're not how to do it, blah, blah, blah. So, of course, there's many, many steps that to be followed before doing. That's the reason why I said also, I tried to explain, first of all, some aesthetic and functional concept before starting the MERPP technique step by step. Because, of course, if you don't know aesthetic and functional parameter to be followed, you cannot do that, because you do anyway. But that is valid for any kind of full mouth rehabilitation as concept. In this case, you have to work with a very minimal thickness restoration. And that is the big point, of course. And that is very delicate. So if you rush the treatment, it will be very complicated. But the concept behind is so high concept, so beautiful concept. Just think about the patient that came, as many others, that needed to do the full mouth rehabilitation in the classic way. You destroy a mouth of a patient. You devitalize all teeth. In this case, even though you maybe have a breakage during the management of the handle of one restoration, because it's very thin, you do another one, or you don't destroy the teeth underneath. So as a concept, even though I know that it's very critical, and you're right, it's very complicated for the maybe young dentists, for example, to to achieve the best result. Maybe you have some mistake done. But again, you're dying in a kind of basis that is incredibly good. For example, you don't devitalize any teeth, and on the contrary, you devitalize practically all teeth. So it's a big difference in terms of concept. Of course, you have to improve yourself. You have to improve step by step. That is, of course, obliged to be done. You have to be very delicate. It's not easy not easy to bond 28 restoration. Not easy at all, for sure. But you have to learn more and more to achieve this result, because behind that you have all teeth that are vital. So that's great result. Anyway, when I did the case of 14 years later with the Sylvian syndrome, I said to my patient, I don't know how many fractures over years. Maybe each year you have to do another 1 or 2 of them. I didn't do anything, zero. It was over my program. It was not thinking at that time that it was possible to achieve this result, frankly speaking. So right now I can tell you that is incredible, even though sometimes it happened to me in the past. No, maybe I put an onlay, it was not fitting well. I was cemented, geez, not cemented well. It happened to everybody, the mistake. What I did, cutting back and do it again. Today I know that you don't need it. It catch there for all life anyway. Just to understand, you can do some little mistake at the beginning, but still, you are talking about an incredible big advantage that is the treatment itself. That is quite new concept, put all together, video increase, plus minimum preparation, etc., that will be very, very useful to have as final concept in our cases. But you're right, you have to be careful anyway. I don't want to say that it's an easy task, no. But if you're delicate, many of my people that work in my courses are doing it regularly. 1,087 arches in my article. Not was just myself, was also other people working with me. Anyway, thank you for the question, because it is a nice precision that was needed to be analyzed to discuss about. Thank you.
Does anyone have any more question? Okay, thank you. Now we would like to present the certificate of appreciation to Dr. Mauro Fradiani. Okay.
Thank you. Thank you very much. And this, okay. Thank you. Thank you. Thanks a lot. Thanks. Thank you. Thank you.
Now it's time for a break. Also, we have lectures upstairs in the other hall room. Thank you.
مبروك التخرج جنان. وين ناوية تدشين أي كلية؟ أكيد كلية الطب، بصير دكتورة علشان أعالج المرضى.
Test 1, 2, 3. Test 1, 2, 3. Test, 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 test.
الو كذي اي ما يسوي الو ما يسوي شيء انا بتوهق اصلا تست ما اقدر الحين
تست تست.
اوكي خلاص تمام اي اكيد تخيل اي لازم اقرا لابسه تست اوكي اوكي
الحمد لله رب العالمين الرحيم مالك يوم الدين نعبد وإياك نستعين